All right, I think we'll get started. Looks like my microphone is still okay. So welcome back. And it's my pleasure now to introduce the George M. Engel Memorial Lecture. This is a lecture that was endowed by alumni of the University of Rochester in honor of George Engel, and I think certainly for those who are in the reunion classes, I don't have to tell you who George Engel was, and I think our speaker will talk about that in any case. So I'll tell you who our speaker is, which is Lawrence G. Smith, Larry Smith, who I know from my first day in medical school. We were actually classmates together at NYU. Prior to that, he had gone to Fordham, and we were together for medical school. Then we sort of separated. He came here to do his internship and residency in internal medicine, but ultimately then actually went into the armed forces. Then came back, was in Stony Brook, and ultimately we both wound up at Mount Sinai at the same time. He initially as the head of the residency program, and then as the head of medical education, essentially the head of the medical school. And we got friendly again, and then but he was very influential for me in that when I was being recruited to come to the University of Rochester, most of my peers did not even acknowledge that something existed west of the Hudson. And most of them told me I would be crazy. Larry said, I had the most wonderful time in Rochester. It's a great medical center and you'll love it. And he was right. And I thank you for that. He then went on, and it's the reason that we've asked him to talk. He went on to leave Sinai and be part really of the development of what we now know as Northwell Health, the largest health system in New York State, I think by far, and one of the largest top 10 health systems in the United States. Really started with a merger of North Shore and LIJ, and then I don't know, you got maybe 27 institutions now, something like that. But not only is Larry physician in chief, but more importantly, the founding dean of the Hofstra Medical School. And I think he had the luxury, which most of us don't have, of not having to start with a long history of how things are done, but to actually try to develop a medical school based on what made sense in the 21st century. So I could think of nobody better to give this George M. Engel lecture. So welcome, Larry.
Mark, thank you very much. And hello to everybody. So George Engel was alive, well, and seeing consults when I was a resident, as well as all the other things he was doing at Rochester that left the place indelibly imprinted with his work and his memory and his legacy. When I was finishing NYU and looking for a residency, you have to understand what NYU prided. NYU prided that every graduate, with the help of Bellevue Hospital and the Manhattan VA, and definitely not NYU's hospital, you learned how to take care of patients almost completely independently. When I look back now, the freedom I was given in a sub-internship was probably greater than senior residents are given today. And as a result of that, I was looking really carefully. I wanted a residency that complemented this kind of macho, I can do anything and keep anybody alive for 24 hours till a smart person tells me what's wrong with the patient. And I looked around and I interviewed at a lot of places. And for those of you who remember this, I was really born at a lucky time because the year I was graduating, the airlines offered Fly America tickets that for a period of X months, you could just keep getting on and off their flights with no increased cost, which allowed me to interview all over the United States without an exceptional cost. And I visited a lot of places. And when I came here, despite the fact that my car caught on fire while driving up here on Route 17, and we did put the fire out. I just want you to know that. The seat was on fire because the battery, which I didn't know was underneath the seat until it started flaming, was shorting because of some reason that I still to this day don't know. But I got to Rochester at about 20 miles an hour from that point to all the way here. And I said, I don't know whether I'll just abandon the car or drive back. We still had to work on that one. But I came here with my wife at the time, and I knew that everything people told me about Strong was what I was looking for, but I wanted to see whether it was real. And I spent the day, I interviewed, I met with the residents. Mostly I met with Dr. Morgan. Then my wife met with Dr. Morgan because she locked her keys in our car that had like what gone on fire, but I don't know why she was so upset that she left the keys in there. I don't know where she was going with it. And Dr. Morgan bought her breakfast, talked to her, called somebody who could open the car up. And as we're getting back into this very smelly car with battery acid having splashed everywhere, she says, I think this is where you should go. I said, really? She says, despite the trip, I think this is where you should go. It then started snowing. But I didn't understand what snow meant in Rochester with that trip. It took me quite a while to understand what 100 inches a winter of snow actually means. So I knew it was right. I knew it was right for me. I didn't understand who all the players were that had created this environment. But very quickly over that time, I understood that Bill Morgan in the Department of Medicine and George Engel and John Romano, who I rarely met, but knew he was an intimate part of this, drove a culture that was patient-centered in a way that I think very few hospitals in the United States at that time were. And so then I went to the chairman of medicine at NYU, Saul Farber, because anybody going into medicine had to meet with him. And he said to me, okay, he says, let's just cut through the nonsense. What's number one on your list? I said, Strong Memorial. And he goes like this. Are you kidding me? You're going to go to a place with a bunch of psychiatrists masquerading as internists? I know he's dead, so he can't deny that he said it. And I sat there and I just smiled and I said, I think it's my first choice. He goes, well, no, we got to talk about this. Tell me your whole list. We go through the list. And I said, well, I already know where I'm putting first. And I think they like my wife. So, and of course I matched here. And we came and my first son was born in September of my internship. And just so you know, he apparently, unbeknownst to me, I was the first father allowed in the delivery room at Strong to watch the birth, and the nurses filed charges against the obstetrician. So that didn't tell me that it was quite the culture I was used to, because at Bellevue, nobody would have noticed if I had been there. But my son was born, and I was having a phenomenally great time as an intern here. I really, truly loved every part of my residency. And I began to understand seeing the patient in a different way. And for those of you who know about the Gold Foundation, which is the foundation that sponsors the Gold Humanism Society and the White Coat Ceremony, and their whole thrust is humanism in medicine, everything that was happening to me then really was what they talk about. And their theme this year, if you look at their national meeting, is who is the patient sitting in front of you? That is the whole theme, because if you can't answer that question in your own mind, you are probably not taking the extra step to meet all the needs of the patient. So, this one? Neither of them. You tell me. I can keep talking without the slide, but it would be nice. Okay. I hope it doesn't take that long to change each one. Okay. So George Engel, born in 1913 in New York City, physician, scientist, teacher, a very daring thinker. And when you read his actual original papers, you will realize how ready he was to break eggs and break the status quo and say what was going on in the teaching of young doctors was really off target. He was a very astute observer of humanity and far better than me at writing about what he was observing. He broke all kinds of status quo. He was an innovator, but I think mostly he was a culture change agent. And when you see what I experienced, you'll realize that being given the privilege of starting a new medical school, it was on the culture that I believe George Engel really brought to this institution that I built the medical school curriculum around, with more modern things like cell phones. So George was born in New York City. He had a medical family. He had an identical twin brother, which influenced him tremendously on the influence of relationships and their breakage on what it means to be a human being and what it means to be a human being who suffers. His brother was a cardiologist at Duke, and George, undergraduate chemistry major at Dartmouth. Then I'm not quite sure what medical school entailed exactly back then, but at Johns Hopkins, certainly one of the top schools, I'm sure maybe the top school at that time. He did a one-year internship at Mount Sinai Hospital that I believe was a rotating internship. He wasn't specific in his own autobiography, but that was the only internships that were going on at the time. And then he did a research fellowship at the Brigham and Women's in psychosomatic disorders. So that already tells you this is already an unusual person. How many people take a year out of their training when training wasn't valued the way it is today to study psychosomatic disorders? And there he met John Romano. They were very symbiotic, and from that moment on worked together. And when John was offered the chairmanship of the psychiatry department at Cincinnati, he insisted that George Engel join him. They stayed there for a short period of time. And then somebody from this place in 1946 offered both of them a job to build a psychosomatic unit and interface with both psychiatry and medicine, but be based in psychiatry. This is very interesting because George Engel actually thought that psychiatrists were amongst the least qualified to teach non-psychiatrist clinicians how to interact with patients, because their model was necessary for their field and not the right model for the non-psychiatric encounters. And he wrote about this all the time, that it was skillful internists and pediatricians and family medicine doctors who were really skillful at interviewing patients, who should watch students and then debrief them and deconstruct what they did in order to mentor them, not psychiatrists. There's many, many papers that say not psychiatrists. I'm not sure why he did that, but he did. And as you know, he started the general clerkship here and the psych liaison fellowship, which strongly influenced me as a resident. And I'll tell you how. And so he retired in 1979 officially, but kept working here until the day of his death in 1979. But I want all of you who have struggled to publish papers and have really high impact and impact factors to understand that George Engel wrote a paper about the new medical model. And what it was that American medicine was so infatuated with science that he felt that there had to be a balance between scientific facts being the arbiter of how you treated patients and who the patient was. And so he wrote this paper that, believe it or not, was published in Science. Now, any of you who understand the top pure scientific journals, it is hard to believe today that in 1977, Science published this paper, which was a thought paper on the biopsychosocial model of medicine, replacing the pure scientific model of medicine and doctoring. And then this paper, which was published, has been cited 19,400 and 39 times as of 2 months ago when I wrote this talk. That isn't bad for a paper that, was really, truly a provocative thought paper. In it, though, he said, well, what's different? He said, human beings are different than animals, lab animals, machines. They're different because we humans, as far as he was believed, were the only creatures on Earth who understood that death was an inevitability for ourselves. And that every time we felt really sick, we worried that that was the entree to our last hurrah and our death. And because of that, they reacted differently than a dog or a cat who had a serious illness, who just worried that you would keep feeding them and were unaware of their inevitable death. The other thing he thought was different about humans was that they suffer when important interpersonal bonds are broken. And here's where he wrote extensively about his relationship with his twin brother. And that when his twin brother died, what that did to him as a person. And he had a beautiful paper about going down to Duke because they were honoring his twin brother. And everywhere he went, people stopped and said, my God, I thought you had been really, really sick. And they all thought he was his twin brother. And how it made him so sad to be there and write about what he thought was going to be what he spoke about. He spoke about the pain of realizing that he had lost somebody who was exactly genetically like himself. So then he says, how else are humans different than any other kind of medicine? And because of it, we have to think about it. And he says, well, we're capable of understanding what's our inner life, our inner experiences, our feelings, and we can tell people what we feel with spoken and written language. And taking care of any other living entity, all you have is the signs and symptoms. You don't have, the dog doesn't suddenly start to tell you about their inner feelings about impending death, their terror at the consequences of the illness, and all the other things that George believed was critical to really have a healer-patient relationship. So critical to all of those was that the physician's work was able to distinctly take on the words of the patient, the inner being of the patient being told to them by the patient, and add that to the laboratory tests and the physical exam and all the other things to put together a complete picture of who is this patient in front of me. And that the only way young doctors learn this is to watch people who are good at it do it, and then for them to try it and be debriefed by the people who are good at it. And that happened to me multiple times during my residency, only that they videotaped. They didn't sit there the whole time watching, but I was sitting with a patient that I had never seen before and had to take a complete history and do a physical and then review that with somebody in the department who was deemed really good at that. And I did that with Dr. Morgan. He was certainly a tough evaluator, but he was certainly a fantastic doctor. And I said to myself, I've been in medical education a long time, but watching students do things that are slow and you can do it so much faster and so much more efficiently, and you're daydreaming and you're thinking about other stuff, we shortchange those students in the value of the experienced clinician watching, critiquing, and suggesting solutions. So he also said, well, what is this physician's stuff? And he says, well, complementary is the need to provide service, and without service, there is no profession. That the process of transition from health to I have an illness to I am a patient, I am a sick person, has been written about since antiquity, and the descriptions have been always consistent. This is something that is innate to human beings. Now, he believed this. I don't know whether that's true, but I will tell you, he truly believed that those transitions were part of life, except for sudden death, and that we needed to be very tuned into those transitions, or we could not be the real caregiver that that patient needed. And that interpersonal encounters between the patient and the physician is the keystone of all medical care. Now, I don't think he was talking about surgeons. They have other roles to play. But the fact of the matter is that the best surgeons are also best physicians. And that there's a contract between the patient and physician, that there is an interpersonal bond, and that the physician owes the patient honoring that bond, and the patient owes the physician honoring that bond. And then he says, well, what we observe, of course, is not nature itself, but it's nature exposed to how we question people. He was obsessed with the Heisenberg uncertainty principle in physics, that every time you measure something, you disturb it, so it isn't the same way as it was when you started out. He wrote a whole bunch about the Heisenberg principle, and since I was a physics major, I thought that was very interesting. But what he says is, we have to be careful how we get data from patients, or we're going to be perverting it with our own biases, with our own techniques, and with not meeting the patient where the patient is. And that the relationship between doctor and patient partakes in intimacy. It's a particular intimacy. It's hopefully not physical intimacy. And it's designated as the art of medicine. But he said intimacy between the doctor and the patient is the essence of medicine. So I came to Strong Memorial Hospital having, despite Dr. Farber's critique of the Department of Medicine being psychiatry in disguise, I have never had a better 3-year experience in my whole life. There's not even the shred of a doubt. I love being here. I'll tell you what happened to me afterwards, but I love being here. Paul Greiner was the acting chair of medicine for the whole 3 years. And Bill Morgan, who co-wrote with George Engel the clinical approach to the patient, was really a person who I feared and loved every day of my residency. And Milton Luria, who was assigned to me as my mentor, and I don't know how many of you remember Milton Luria, but he was a wonderful physician and a paternalistic teacher who always tried to figure out what you needed from him and deliver on it. And Mac Lipkin was my med psych fellow. And lo and behold, Mac left here and went to NYU. And I saw Mac almost monthly for the rest of my career. And he's still at NYU, I think, although he's looking a little old to be still there. But Mac was fantastic. And as you remember, the med psych fellows were there to help the residents work through difficult interpersonal situations with their patients. And the absolutely amazing attending staff. One of the things I learned, but you can't quote me on this, the difference between all my experiences on the island of Manhattan, which was not only at the 3 hospitals at NYU, but in my 4th year, I probably went to every other hospital to see whether I wanted to be a resident there by doing an elective. I never realized at the end of all of that excellence and arrogance weren't intimately intertwined, and you couldn't be excellent unless you were arrogant. Because I never met anybody who was called doctor that people said was excellent, who I couldn't find intolerably arrogant. And then I came to Rochester, and like almost nobody was like that. And I said, wow, isn't this amazing how you can mistaken that you have to behave in this strange way to prove to people that you're excellent, as opposed to being as nice to your colleagues as you are to your patients. And that kick-started me in just loving this place. My fellow residents were fantastic. My best friend in residency was Dr. Dawn Bordley. I don't know how many of you know Dawn. Dawn spent the entire 3 years saying they're going to fire you. And I never understood why he would say that with such passion. But maybe you'll understand before the lecture's out. And I loved my patients. I told Mark, I was the only resident in the resident clinic who asked for an extra afternoon in my third year because I had so many patients in my clinic that I couldn't see them in one afternoon a week. And the nurses, I just asked the nurses that. I just said, can you give me an extra session for my patients? They said, sure. Nobody ever checked. Dr. Luria wasn't around that extra session. Nobody was around, but I had a humongous patient practice, and it set me in the path that I knew I really wanted to be a primary care physician. So, what was different about this place? It focused on the patient. I was told to know them as people, and Bill Streck, who was my chief resident in my internship, met with me and said, I'm going to give you a tip that I did that will make everything change in your residency. Every afternoon, there's always a lull time, unless you're wildly admitting patients. Take that lull time and sit down with each one of your patients for 10 minutes and only talk about who they are and what they like and whether they're a Yankee fan or whatever. And don't talk any medicine or anything about why they're there medically. Just talk about who they are and who you are. And he said, you do that and you will have the best residency anybody can give you. So I thought that was great. And I must have been very concrete at the time. So that's exactly what I did. And so one day on a Saturday morning when I was on call, one of my co-residents is there in the afternoon and he goes, what's going on this floor? How come all of your patients have the Yankee ball game on their television? I said, they're waiting for me to come in and they know I'll stay longer if the Yankee game is on. We were very good at, this was one of the first night floats in the entire United States. It was sadly created because of the death of a resident. But in response to it, the ability of this program to be humanistic and yet highly intense was phenomenal. We covered for each other. We did resi-turning. Does anybody here remember resi-turning? So resi-turning was when you thought you didn't need that intern around and they were really looking tired as can be. And when they walked in the morning at 6 o'clock, you were sitting there and you handed them a cup of coffee and said, go home. The medical student's so good, I don't need you. But the day before, I would tell the medical student, you're going to be my intern tomorrow. And they were so hyped up. They were like bouncing off the floor. And I sent the intern home and said, go to sleep and then do something today, but you're done. And I always did that on every rotation because for one thing, I got out earlier, but we never told the interns that. But the medical students loved it and the interns loved it. But that was also from Bill Streck. Make sure you always resi-turn. And I did. Tuesday lunches, all the medical residents met up in the medicine conference room. I think it was on the 3rd floor. And it was always a non-medicine topic. It was all kinds of things, classical music, cartography. And that was where Dr. Morgan said, you guys need more empathy for the patients. And he made us all take a sublingual nitroglycerin. Oh, yeah. Oh, okay. Well, that brought new empathy to people that I was saying, stick your tongue out, I'm putting this nitroglycerin in. It was an excellent time. We bonded very well. We only ate pizza. It wasn't so good for our cholesterol, but everything else went well. Bedside teaching, always. So this was the first time I ever realized that there was a hospital where no one talked about the patient except in the patient's room. And for all those 3 years, I never saw anybody discuss the patient except in the presence of the patient. Maybe if they were floridly psychotic, they would have not done that. But that was not, and sometimes you did a little strategy about what you were going to accomplish in the visit. But always you talked about the patient and asked them did they understand, asked them if they wanted to add anything. And then I've been to all these different places since then where no one ever would dare to go in the patient's room and talk about them. I'm going, I don't get it. Why don't you go in the patient's room? They said, well, what would happen? They might overhear us. I said, that's good. I think you actually should talk to them about what you're thinking. And so it was so fantastic because at Bellevue, I never went in the patient's room with an attending. I don't think ever in all 4 years. Residents came in the room to make sure you weren't killing people, but but the attendings never. And people even then would walk out to converse about the patient as opposed to talk right in front of them. And excellence was really the minimal expectation here. And that was also different. So nobody bragged about, how smart you were or anything, because that was how you got in the door. It's no big deal. Just use it to take care of patients. Now, there were two really bad things about my internship. One was the unlimited amount of Dixie Cup ice cream in the residence lounge. I gained 35 pounds because I substituted eating ice cream for sleeping. It was really tough, and no one prepared me for what 100 inches of snow in a winter is actually like. But such is life. So while I was a resident, though, really stressful things happened to me. My wife was pregnant with our second child, Kevin, when she started to have problems swallowing. She went to see an ear, nose, and throat person here who said, you have globus hystericus like all pregnant women. Just relax and take it easy. And then she was still not doing well. And one night I'm looking across at the few times we were eating dinner together and reached over and touched her supraclavicular area, which was rock hard with matted lymph nodes. And I said to her, God, you got to go see somebody tomorrow. And I called Paul Greiner, who said, send her over right now. I'll see her. And she had Hodgkin's disease, and she was pregnant with my second son. That's when I learned that ultrasound wasn't so accurate back then. So when they decided it was time to deliver him so that they could begin giving chemotherapy, they gave her a small amount of radiation because she was constricting her trachea. And Kevin was born really premature. That ultrasound was off by at least 6 or 8 weeks. And he was in the NICU. And I'm on call as a second-year resident. And just to tell you how much we stuck together, I was the resident in the emergency room, so I had one medicine and one surgical intern, and we were seeing everybody who walked in the emergency room. And the pediatric resident calls me and says, listen, Dr. Smith, I don't know you, but I don't think your son's going to live the night. And I think you might want to come up here. So I'm sitting there staring at the room, and the intern runs up and says, what is the matter? And I told him, and he called the only other medicine resident in the hospital who was covering the ICU and CCU with interns. And he called me up and said, I'll be down in 5 minutes. Let me just get the intern straight, and I'll cover the ER and the units. I said, Larry, you can't do that. Larry German, he became a cardiologist. And he said, if you don't get out of here, I will have to pick you up and throw you out of here. You go up to that NICU, you sit down in a chair, and you don't leave your son's side. And that was the last I saw of him or of any work that night. And somehow one resident covered the entire emergency room and the 2 ICUs with no problems, because we were supermen and superwomen, and we did have women in our residency. But that was, nobody asked for thank you for that. That was like every person in the program would have done without a moment's hesitation. So my wife became a connoisseur of doctors, really, because for the next 47 years before she passed away from radiation-induced heart disease from the Hodgkin's, she was seeing doctors all the time. And she would say to me, you're never going to believe what this doctor they sent me to did, or what he didn't do, or what he asked me. And I always remember, of all the things, the thing that she eventually got to the point where she would call up and say, if you type on your computer while I am in the room, I will not see you. Just tell me yes or no and don't lie to me. If you even reached for the keyboard, I am out of there. Because she had just seen a hematologist for pancytopenia, probably also radiation-induced, and he was typing away, and she told him about a problem she had, which was very, very rare, but it was from head and neck radiation. And she had seen 20 doctors and none of them knew what it was. And he didn't stop and say, what is that? Tell me. And so she smacked the desk and said, look at me, look here. What did I just tell you? And he didn't know. And she got up, she put her clothes and says, when you decide to be a real doctor, I'll be back. But I'll never be back to you. But I hope some patients actually get a real doctor when they come to see you. And she walked out. She told me stories like this for 40 years. And she was as astute at whether the doctor cared about her or not as any patient I ever saw. And she was a big piece of why I learned how to do that. So then I go into the US Army as the last person, I think, in history that actually served from the Vietnam draft, because they never let doctors and dentists out. So the war was over for 8 years. But no, 2 weeks before I left Rochester, I got a little letter that said, you will please report to such and such Army base on July 2nd. Glad to have you. Welcome to the Army Medical Corps. I did call up and say, I refuse to go to this place that you're sending me to because my wife just got over Hodgkin's disease. I have to be at a place that actually has a hematologist within 100 miles. And they actually did change where I went. I arrived at the hospital and the general, by the way, if anybody's been in the military, you know that when a doctor starts calling themselves general and you captain, you're in big trouble. Only bad things can come from that conversation. I get there and he says to me, you are in such luck, you are going to run the entire nephrology unit. This was at Fitzsimmons Army Hospital, an 1,800 bed hospital. I said, what do you mean I'm going to run the renal unit? I said, I didn't even do renal as an elective. I didn't like it. He says, doesn't matter, you can do it. I said, I don't think so. I don't think so. He says, this isn't a question. This is an order, son. I said, oh. I said, I don't think I've ever touched a dialysis machine. He says, doesn't matter. The nurses know everything. So I go downstairs. There's a point to this story. I go downstairs to the renal unit, and there's a guy who looks like he popped out of a protest movement of the 1960s with long hair, sitting at a desk with his sneakers up. And he looks up and he goes, so are you the next dumb schmuck that the armies are sending down here to do nephrology who doesn't know anything about a kidney? I said, as a matter of fact, I am. He says, he goes, God, my job's going to be safe because I'll continue working here a couple of times a week to save the patients' lives. He says, where the hell did you come from? And I said, I just finished my residency at Strong Memorial, and dead silence. And he stands up and hugs me and says, I just left Strong Memorial, finishing my residency. And his name is Stu Linus. I don't know if any of you ever remember Stu, but he left, I think, the day before I started as an intern. And the reason I'm bringing it up, Stu helped me. He taught me all kinds of things, especially to biopsy people, because the Army insisted that anyone with proteinuria or hematuria be biopsied. So I did a lot of kidney biopsies. Yeah, don't just think about it. And nobody would support me. So I used to do my own fluoroscopy and then biopsy people in the radiology and pray I hit the kidney and not the aorta, which I never did. But Stu was just named this past year as the best doctor in the city of Denver, as a research and subspecialty nephrologist. And those are the kind of people that this residency produced. People who could be experts in all kinds of things, but never ever forgot first and foremost their patients' doctors. And so when I saw that, because he sent it to me, we've stayed friends ever since he insulted me when I walked in that nephrology office. I just want you to know how deeply the teaching here came. So then I was asked to start a new medical school. Northwell Health was growing and growing and growing. We had the second or third largest GME program in the United States, but we were teaching everybody else's medical students. And sometimes we did their curriculum, sometimes we didn't care, sometimes they didn't care. And finally, I convinced Mike Dowling, we need to build a medical school. We can do this. And he said, good, you're the new dean. I said, oh, well, thank you. He says, and you're going to continue to run the senior physician for the health system. I said, oh, okay. It was good for a few seconds. And I started to plan the medical school. And I hired somebody from Boston University who was a really good friend of mine, Dave Battinelli. And Dave and I were soulmates in terms of what makes a good doctor and what a school should do to produce them. And we decided that there were two important things to do to make this medical school work. One was to realize that the cell phone had eliminated brute memory of facts. And so we had to teach science linked to patients without testing people, that they memorized a bunch of facts, that they would forget forever until they actually saw a patient. And then they maybe remember it for a while, and then it would change and they'd be using the wrong facts. And so how do you teach the science of medicine linked to the patient without testing people on memorizing endless streams of facts that they don't even know why what they're doing is basically studying for a test, not studying to be a doctor. And I think we did this. It took a lot of work. We took a lot of people and brought them in as consultants and asked us, what do you think about this? Everybody said the same thing, by the way. It's exactly how you should train doctors. It's too bad they'll flunk the USMLE and never get a residency. And that worried me for a while because, you know, all my friends said that. And they said, this is really great. Your students are going to love this until they can't get a residency. Well, so we decided, number one, no lectures. Because lectures are all about laying out facts that need to be remembered. But we do lots of whole class exercises, usually triggered by a real case, and usually teaching people how to sort and think and put differential diagnosis and pathophysiologic problems into framing around the patient. And every single fact our students learn is learned in the context of an actual case. And they don't have the answers. They get 2 cases every Monday. There's 9 students. There's a faculty member who has no content expertise in what the cases are on, and is just there to prevent people arguing and everybody participating, but that's it. And our students are so good at doing this by the end of the first month. So what's the first course? We said, I was quoted in the newspapers saying, somebody asked me in the Newsday, which is the Long Island newspaper, what's wrong with curriculum in medical school? And I said, well, here's what it is. At the end of 2 years of medical school at NYU, I was $20,000 in debt. I had been studying 120-hour work weeks of study, and I'm less valuable in a family catastrophe than a Boy Scout. And they quoted me on that. I said, what did I pay for all this if I learned no skills of doctoring for all that time? So our first course in medical school, it's 9 weeks long. Every clinical experience, twice a week, they ride the ambulances that we ride all over New York City, Long Island, and Westchester. And their final exam is the EMT licensing exam. And every one of our students by 9 weeks into medical school is a licensed EMT. And during COVID, when they started sequestering the not so sick COVID patients, they had a call for EMTs to staff these huge auditoriums filled with COVID patients. And our first year students managed that for the county. And they did it phenomenally well. So that was the first class. And then after that, there's the courses have funny names, but you'll see what they are. So we teach them communication with the patients based on lots of algorithms. But the biggest thing is that we built a simulation center like the National Board. And we videotaped our students interviewing and examining patients 100 times each during medical school. And they sit with their faculty advisors and go over pieces of it. The patients are trained to give them feedback about how they did the physical exam, whether they responded appropriately to a cue that the patient threw out, and they just, scribbled it on a sheet of paper, and it was like, I think I'm dying. And they just looked and kept writing because they were supposed to have the history, outlined before the interview was over. They go through that. at least 100 times in the school. But every course, in the final exam of the course, there's an exercise with a simulator where they work in teams and are videoed, and an exercise with half, so I think like eight simulated patients with problems related to that course. And those are intimately part of their grade. So, just to give you an idea how many communication sessions we formally structurally have where faculty watch either the video or the actual event and debrief them. These are the numbers in the first 2 years of medical school of how many times they're actually observed with patients in increasing exercises that are more and more complex in what we expect them to do with those patients. So you can see we invested a lot of faculty time and money to teach this. And so we built on that. About the only thing that we decided to stop saying was the chief complaint. And so we just say the chief concern, because there's something derogatory about patients coming in complaining. So David was in charge of recruiting our faculty. And so I watched him one day, and he would go to a hospital, and maybe there'd be 50 attending physicians would show up, all wanting to be on the med school's faculty. And everybody had to do something. And he would say, here's who we're looking for. This is really simple. Just be introspective. And if you don't qualify, don't raise your hand ever. We only want people who every day wake up and say, God, am I lucky? I love being a doctor. And if you don't say that, if you wake up and say, damn, United Healthcare is ripping me off again, please, please, please never even think about interacting with our medical students. Because we only want doctors who love being doctors. Now, who do you think objected to that most vehemently? The psychiatrists. They said, that's ridiculous. That's impossible to ask somebody that. You're creating psychic stress in everybody in the room. I was glad David was up there taking the heat. So again, our first course, CPR. By the way, we get the New York City Fire Department to do their final exam at the disaster center on Randall's Island. And they learn how to rescue people from fires in the subway, and things fall on them, and all kinds of things that go along with having worked as EMTs for the whole course. And of course, now we put tremendous stress on using the social determinants of health as a way of conceptualizing who is this patient. They all know the thing. They all know that the zip code predicts your health better than any other document in your life. And then we ask our students to get that information and use it in conceptualizing how to take care of this patient. And so they're really good at interacting with standardized patients, but they're really good at interacting with real patients. And the single number one thing that we've gotten back from the residency directors of where our students have gone in these first 11 years is your students are the most comfortable with patients of any starting interns we have ever seen, which means that all this time wasn't wasted, because they should have been more comfortable than a standard medical school curriculum. And I believe that this medical school, which I visited multiple times before building our curriculum, does very much many of these similar things. So this is what the first 100 weeks, that's the first 2 years of medical school, but it's a continuous curriculum. So we just call it the first 100 weeks. All the courses are collected around a common pathophysiologic theme with cute names. I didn't pick the names. And the exams are always a full week where they see patients, standardized patients. They take written exams, no multiple choice. We never ask a multiple choice question ever in our medical school. It is all essay and short answer and oral exams for every single course, plus seeing standardized patients, plus doing simulation, plus doing an exercise in the structure lab. And we call it structure instead of anatomy, because on day one of medical school, we'd start teaching them ultrasound as a tool for the physical exam in every patient. So these kids are so good at ultrasound by the time they graduate, it's scary. And so that week off, they don't have classes, but they have all of these assessments, because when you're doing non-multiple choice assessment takes a lot of time. It takes a lot of faculty time. It takes a lot of student time. So you have to clear the deck and say, for a whole week, we're going to do nothing but assess you. The courses in the first 2 years are all pass fail, but they get lots of feedback on strengths and weaknesses. By the way, when the first class got to step 1 and we got the scores back, nobody failed. That was the biggest relief of my entire time planning this, because all those people who told me they were all going to self-destruct over that exam, but they didn't. And so again, minimal lectures, and the lectures we use, we now understand, is to organize material that they've learned for like a week or two. It's not to teach them just facts. It's how to put these things into a format that makes it easy to remember and when it applies to patients. They're in small groups constantly. And when I had the medical school building built, we had designed the curriculum. And the architects came and I put the curriculum down in front of them and I said, build me a building for this curriculum. And I said, here's my preference. Number 1, no carpeting, because I want them to be able to study all night long and eat pizza and not be yelled at because the pizza is stuck on the carpet floor. I said, I want every floor to tolerate pizza. I said, that's a requirement. I said, number 2, it's got to have space for every conceivable size group, from individual quiet booths to rooms that can handle groups of 10 that want to study together. And they were laughing at me, but they said, this is really great. I said, number 3 is I hate the color turquoise. So I don't want anything in this building turquoise. They looked at me and said, you're kidding, right? I said, why would I kid? This is my school. I don't like turquoise. They did fill one room with turquoise and laughed at me and then took it out like a week later. I don't know where those came from. We have a lot of time for practice, and we now know, because we have security guards 24 hours a day because the students never go home, is what's the average time that students in the first 2 years go home from the school. And it's somewhere between 12 and 1 at night. And all that time they're with their friends studying, they're eating, the cafeteria is open, plus it's a college campus, you can get food all over the place. And they all take breaks. We did put up a basketball court and we put up a volleyball court, and we want them to exercise. So then we said, connect, co-construct, collaborate with one another. The 3-function model of how people work together to make patients better. Who is the patient? What is the context? So when I came back from the US Army, I wanted a job in academics, but my wife wanted to come home. She was tired. She had been beaten up by all this Hodgkin's, by a premature baby that was nearly dying, and then 2 years in the US Army, which didn't win her heart and mind. And so I couldn't find an academic position because all I've been doing is taking care of tons of patients all those years. And so my general practitioner growing up from Long Island called me up and said, the best group in this whole region is looking for a young internist. I gave them your name, they're going to call you. So I talked to this Dr. Eastman for a long time. He says, okay, you're hired. I said, wait a second, I've got to come and see you guys. And like, how much are you going to pay me? He says, well, we have a whole standard thing for that. I said, okay. I said, but can I come and like meet you guys and see the place? He says, well, if you insist. I said, okay. So they bring me out and they have a barbecue in his backyard. And I really like these. These were great doctors. Every one of them had started in an academic hospital and had moved into this practice, most from Columbia Presbyterian. And they were really, really smart doctors. So I said, okay. And I grabbed the guy that I knew was in charge of salaries. And I said, you got to tell me, how much am I starting? It was 25% less than my salary in the Army. I said, you don't think I can go back home to Denver right now and show my wife this, do you? You are kidding, right? He goes, well, how much do you need? I said, well, I need more than the US Army salary for a general internist. He said, well, how much will that be? So I tell him, he says, oh my God, oh my God, oh my God, we've never started somebody that high. That was $34,000 for the year. I said, well, you got to give me that. He said, well, it doesn't matter, because once you bring in more money than we've lent you for this salary, you just get minus the overhead, whatever you bring in is your salary. I said, I can't tell my wife this. I can't show her this contract. We're going to have to cancel this. He goes, okay, fine. We'll give you 35. I said, okay, that's good. I think I can sell it to her. Those group of doctors were unbelievable master clinicians. So I remember a doctor named Reese Alsop, and Reese had gone to Harvard as a theater major, and then to Columbia Medical School. And he was a general internist who was as smart as anybody I ever saw. And he was getting consults routinely from the medical subspecialists to try to figure out what was going on with the patient. So I said to him, Reese, what do you do that all of your patients want to stay with you and you figure things out when other people who are way more specialized can't? He says two things. When a lot of doctors haven't figured it out, you book a lot of extra time because it's not going to be simple. I'm not going to have a brainstorm in the first 30 seconds of what's going on. He said the second thing is I look at the patient really carefully and I make myself become the patient, the doctor they need today. He says the stupidest thing you can ever tell a doctor is be yourself. He said, they don't give a damn whether you're yourself. They want the doctor they need because they're scared, because they're worried, because they feel awful, because they're having family problems. He said, you have to become the doctor the patient needs right then and there. I said, so that's why your theater, going to school for theater helped? He says, absolutely. I never thought of that. He says, but absolutely. He says, it's really important to understand that if you want patients to trust you, you have to let them know by being the kind of doctor they're looking for at that time. And I never forgot that. And I think it fits a lot with what we're talking today and certainly what the Gold Society is talking about. And so again, we go through, and after the ambulances, we have 450 practices of individual doctors who have volunteered from the beginning of the medical school to take students in. For each course, they have a different specialist that they go with. One student, one doctor, one office, once a week for a half a day. And we send them what they've studied the previous week so that they can find a patient that's relevant to what they're actually studying. And the specialty is relevant to the whole course. In 11 years, we have had 4 of those 450 drop out, with hundreds of other doctors pleading to be part of it. But we have all the doctors we need. No one has quit. And they all come to graduation. They're all invited as the special mentors of the students. And they all cheer when their student's name gets called on the stage. And it's been amazing. So once again, when Dave said, I only want people who love being a doctor, they all stood up. They didn't stand up in that room, but they were all there waiting for somebody to ask them that. And it's been absolutely fantastic. So social determinants, I think if George Engel were alive when the social determinants were being so data-driven in terms of the detriment to patients, he would have included that in all of his models of thinking. And I think it's sad that he didn't get to see the data that we can generate now with computerized records to look at those types of things. This is what a week in the first 2 years looks like. They deconstruct 2 cases on Monday. These are really tough cases. If I showed you these cases, you would say the fellows would have trouble deconstructing them. And then they have a few sessions that are critically important to solving those cases. Then they have an afternoon where they can ask any question they want. They can come in, and the faculty of these courses sit for 3 hours and do nothing but answer questions and explain things that the students are confused with. Then they go to the office. They decide what day and what time. We put it as a block. Here it's on Tuesday morning, but they work with the doctor they're working with, and they find the best time between the two, and they spend a half a day with that doctor every single week. And then the cases are all linked to the basic science. The structure lab is linked to it. So for a diabetic patient, they would be looking for signs and symptoms of vascular and diabetic disease in the cadaver. They would be looking at pathologic slides. Our pathology department really stepped up to the plate. We have probably 20,000 pathology slides, all indexed, so that if we want to show them a glomerulosclerosis of the kidney, or a chronic bile duct obstruction, we have slides of almost anything you could think of. And our pathology teacher always puts 2 slides up, and for 1 hour asks questions of the class about comparing and contrasting the 2 slides. He has been voted the best teacher in the school every year the school has existed. Just wanted you to think about that. We love him too. Okay. And then this is the exam week. They do simulation, they do OSCE patients, they go in the structure lab and have radiology round. It may be CAT scans and MRIs. It's finding something on the cadaver. And every cadaver group has one exercise for the last week of dissecting their cadaver with radiologic supplementation about a problem they were asked to solve, and teach it to the whole rest of the class as they go in rotation. So for instance, I'll give you an example of one that's easy to think about. A group could be given a thing that says, show anatomically why it is so common to have erectile dysfunction after a prostatectomy. And that's all they're given, and they can get any anatomic visualizations plus the cadaver to teach all the other students in the class the answer to that question. And that's part of their grade. Then they have the final essay exam, and we let them take a national board exam. We score it and return it to them. It has nothing to do with any grades. But we were so nervous that they were all going to fail that test that we decided we would at least let them practice it. So then in the 3rd and 4th year, in the 3rd year, we cluster the clerkships. So they all do neurology and psychiatry and flip-flop back together. And we look at all the overlap between neurology and psychiatry, and the exams do an interplay between those two. And the patient, the doctors they're going to see in that clinical afternoon every week are linked to those specialties. Then we do pediatrics and OBGYN together. And then medicine is linked to surgery, but medicine, there's an elective in medicine that has to be a medicine subspecialty that they get to do for a week. And in surgery, they get the same thing. In the 4th year, we have 3 true sub-internships, still just like the old days. 2 students replace an intern. There is no intern. They write all the notes. They write all the orders. We've gotten the hospital to agree to that. And they take all the call, and they do medicine or pediatrics. Sometimes if someone really pleads, we'll let them do family medicine. They do ICU, critical care, and I'll get back to that. And they do a surgical specialty. In the ICU, our ethics team spends time with every student who's in their clerkship, in their sub-internship in the ICU, where they must be engaged as the physician in a patient-family discussion of this patient is never going to get better, and we need to plan how to exit this critical care in a dignified way. Well, this patient came in brain dead, and they have to be part of that discussion. And believe me, it happens so often. And the ethics people are spectacular with it. And all the students talk about it continuously. They don't ever take that away. It's so important for us to watch these experienced people do that and have those conversations. And then we take a week off in the middle of the third year, and my faculty decides on something that's really important. One time we did it on opioids, one on patients with disabilities and health equity, and I don't know what this year is because it hasn't come up yet. Okay. And that's what the exams look like in the third and fourth year. So, Dr. Engel. So I really liked what Dr. Morgan and Dr. Engel did here. They made this whole place so special for me. And I had a strange patient as a senior resident on the floors. I believe it was on 73400. I think she was in the first large room to the right as you walk down the room. And she came from somewhere in the farmlands of southern New York State before the Pennsylvania border. She grew up on a farm, and she was admitted by one of the gastroenterologists for refractory abdominal pain. And if only that were the story, it would have been simple, but it wasn't. This was her third major hospital to be at, and the first two did exploratory laparotomies to find nothing. Yet she had, if you wanted to ever have somebody with an acute abdomen, she had an acute abdomen. Rigid, she was running fevers, she was tachycardic, and she was crying all the time. And this attending, I actually had never met with before. She was not somebody that I knew well, even though I was a senior resident. And he was frustrated by the whole thing. And I'm not quite sure why he ever even took this patient on, since it was going to take much more than a colonoscopy to figure this woman out. And finally, it was so ridiculous. This was going on and on and on and on and on. So I called Dr. Engel as a consultant without talking to the attending. I figured, Dr. Engel, he's like this icon. He wanders the hall all the time. I'm going to ask him if he'll see the patient. Two things happened. He arrived with all this biopsychosocial fellows to see this patient, but I had to be there and present the patient to him. And the attending was so angry at me. I won't tell you what he said about Dr. Engel, but it wasn't flattering. And said he was never going to see the patient again and stormed out and never came back. Yeah, I asked myself that too. Now what am I going to do? But it didn't matter. So Dr. Engel talking to this young woman, the fellows are there. He would ask, what do you think? He would ask me, Dr. Smith, do you know whether she's ever had this or that? He's going back and forth, and he's holding her hand. He's saying, we're here to help you and all this. And he examines her abdomen, and all of that. And he says, well, listen, we will be back until we solve this problem. And he says to everybody, why don't we see what we found today? When we walk out of the room into the doctor's room, and he says, so what do you think? To his fellows, not to me. He knew I was very frustrated, and he knew that I really thought this was most likely psychosomatic, because most people don't have two laparotomies. But she was, if I wanted to ever use her for a standardized patient, this woman could imitate an acute abdomen like nobody I ever saw. So he says to us, finally, he says, you do know that all these symptoms she's faking, she's creating, none of them are real. I'm sitting there. He says, for instance, I walked in and picked up the clipboard, and it said that she had 102.8 fever 30 minutes before we came in the room. And she was absolutely normothermic. Her hands, her arms, her abdomen, everything was not even close to a fever. I'm saying, okay. He says, so you need to have a conversation with her and confront her and tell her you understand that these are all created symptoms, and we're here to help her, and we have to move forward, so we can't keep talking about these symptoms that aren't real. I said, so who's going to do this? He goes, you're going to do this. Oh God, I should never have done this. I can see this is gonna go to hell. And I said, well, what do you think? How do we do this? He says, well, the first thing you do, now this is also from days past, is she knows all the nurses on the floor. I said, yes, you're right. They're all like her best friends now. You have them take her down to the cafeteria because she needs a break from the hospital room and buy her dessert. And you search her room. So I'm thinking, I'm not telling anybody I'm searching this person's room, but if that's what he wants me to do, we come back with 9 thermometers rolled into the sides of the mattress with sublingual ephedrine tablets in her bedside stand to give her tachycardia, and a whole bunch of other things that I can't even figure out what symptom they could have possibly caused. But she had a whole array of things she was doing. But the 2 biggest ones, it was still mercury thermometers back then. She had thermometers set at every fever you could think of, and swapped them out as the nurses did it. And she was just sleight of hand. And okay, so now I know for sure he's right, and I go in there and I said, is anybody supposed to come with me? He goes, no, you're her doctor. You called me. You just have to get her to admit that she's doing this. And then we will step in and we will move her over to our wing and we will figure out what has caused the pain in this woman. But first, you got to get rid of this medical workup, which is going nowhere and never will. So I sit with her and I just keep telling her, listen, you know that I'm on your side. I've been taking care of you for weeks. And we now know that you're creating these symptoms and they're not real. And we really need to get beyond that and understand why you're so sick. And she started screaming, how could you do this? I trusted you. How could you say this to me? I'm making up these symptoms, on and on. And I'm like, we're having runs of VTAC. And at it, like the 5th or 6th time, I said, well, we know it, so let's just talk about it. She said, well, I didn't do it every time. I said, oh, thank God, thank God. And then we talked for probably another hour. And then I said, listen, the doctors who were in here are experts in this, in pain, real pain that's very bad, created because of other reasons other than the organs are distressed. And I'm going to have them come in and they're going to start talking with you. And after 2 days, they moved her over to our wing. And every day I would call up and say, any news, any news. And about a week and a half later, they said, oh God, yes. She told us when this started. She was on a dairy farm. She was the only daughter. Her mother died. Her father berated her continuously for not being supportive of him trying to run the dairy farm himself. And at the end of months of this, he put a shotgun in his mouth and fired it in front of her.
Oh my God.
Yes. I mean, even the psychiatrist said, this is like unbelievable. And she stayed there for a month or 2, which even then was a little long for a psychiatry admission. And I saw her twice more before I left, and she was like a completely different person. And that was my one and only personal, intimate encounter with Dr. George Engel. It was toward the end of my residency. I always liked Dr. Morgan and Dr. Engel, but after that, my level of respect and my level of understanding of his understanding of how human beings work was really a tribute to him, this institution, and everything I experienced. So I'll stop there and thank you.
Reception, and we'll take some questions, but there is a gray BMW with Florida plates still running in the front SMD parking lot, first parking space. So if any of you have a car that looks like that, please go before your battery does.
So if anybody wants to add comments, I don't know that I can answer questions, but I think he was an important part for this institution, and certainly for my coming here and it is disappointing. And one of my chief residents in Alcona went to medical school here, and he's sitting right over there. Peter, hello. Thank you for being here.
Right.
Yes.
Has the computer changed the style of George Engel? There's not a good human interaction between doctors and patients now because they're looking at the computer screen. And I've noticed this in my own encounters with my own physicians. And I wonder how you're teaching that. I mean, how you're dealing with that.
So I think that's a really good thing, because I think the EMR done in real time is a big detriment to the doctor-patient communication, and not done in real time is a real destruction of the doctor's personal life if he's doing it all at the end of the day after all the patients have been seen. And so I think there is only one answer to this. And if I were the rabble-rouser to lead all of you, I would say no doctor should ever be asked to touch a keyboard while seeing patients, and somebody should pay for the person in the room, or maybe it's an AI computer, maybe artificial intelligence, and listen to what's going on and write the correct note for that business. But that doctor should never be playing around with the computer when they're talking to the patient. No, I know that. Believe me, I know it. What are you teaching in medical school? So we're teaching the medical students to always have prolonged pauses. And what we encourage them to do is to write a 1 or 2 words that would remind them what should go back into the note later on, but not to try to type a note that is ready to go at the end of the encounter. But if you look at some of the ACT writings, I think really, Christine Sinsky, if you want to look somebody up, when she hired people in her big internal medicine practice in the Midwest, so that no one had to ever type the EMR, no doctor. That doctor satisfaction went through the roof. There was an incremental increase in seeing patients, but everybody went home when the last patient left. And, if there was really a doubt that a note captured the right thing, those were few and far between, because the doctor had their own person doing that. So they knew the strengths and weaknesses of that person within a very short time. And always the slight increase in the patients paid for the person who was doing that time completely. I think we just have not taken control of medicine back. I mean, we're working for Mark, and he's got to answer to the board. But he doesn't care. He would just as soon hire all those scribes. The fact of the matter is, I think we got to get doctors' fingers away from the keyboard of the computer during the time they're interacting with the patient. I think it's as simple as that. And anything else isn't going to work.
All right. If there are no other questions, we'll be around. Oh,
One more right here.
Thank you. This is not a question. I just wanted to share an experience I had regarding Dr. Engel. I graduated in '67 from the medical school, and it just so happened that Dr. Engel was in an assisted living at the Highlands in Pittsford, and his room was right next to my mother-in-law's room. And I had the incredible experience of getting to know him on a completely different level. He recognized me. We talked about a little bit about medical school, and he would have me, and I would visit my mother-in-law twice a year, April, October. And he, starting on the second year or so, he started inviting me over for tea during the 4 to 5 days I was there. And he would do that each time. And eventually he got to the point where he asked me if I would review something. He had written an introduction to a book written by one of his colleagues. Would you mind reading this and seeing what you think? I couldn't believe it. I was a medical student with Dr. Engel. We had incredible respect and a certain amount of fear and trepidation when we were presenting. And yet I got to know him on a completely different level. And it was such an incredible experience to get to know him that way. And the one thing I wanted to share, he said, the most important thing I ever did was teach medical students. And that was beautiful.
Thank you.
So let me thank Larry for a marvelous talk.